Georgia's Center for Personalized Health on the former ExxonMobil campus around the integration of precision medicine and much larger data sets than we've ever dealt with into the understanding of the human person, their families, their lives, and how we can actually help them get healthier.
Well, the future's here. It's just not evenly distributed yet.
Correct. And do we know who originally quoted that?
Yes.
Correct.
Who said that? He gets a prize. We should have like little Nerf things we can throw at him. So we'll just get started with the first thing, which I think is, to me, is really interesting because so much focus in our business is around accountable care organizations, value-based payments, care coordination is really key. And you with having a number of clinics along with your hospital probably deal with this quite a bit. How do we improve collaboration and communication between providers, and particularly, I think, between hospitals and ambulatory practices, but also between physicians, between different primary care docs and the specialists, referral patterns and the like. So there's a lot we can dig into there, and maybe I'll pick on Gene first because he warned me. He said, I like to talk, so I'm gonna have to say, okay, thank you, Gene.
So they don't let me out much, so it's nice when I get out of the office and get to talk a little bit. Plus, I didn't know they were going to use the pictures, and I hate that picture. I look mean or angry or something. But I don't know what the story is. Like, my assistant one day said, go downstairs, I got to take your picture, and it was like 20 seconds, and that was it, and they scurried me back off. So a lot to say on that topic. We are wedged between New Orleans and Mobile, Alabama. And this is Gulfport, Mississippi, so I'm actually from Houston. I came from Houston over to Gulfport. All of my family is about 35 miles north of here. My wife is currently about 50 miles north of here, and our house is almost flooding. She said the pool hadn't quite overflowed yet, but it's probably going to get there. But in Mississippi, that population, just to be blunt, is fairly unhealthy, right? You want diabetes, obesity, CHF, or hypertension, you really just have to reach out and touch someone, because from our employees to, sorry if, I know this is being recorded, but very unhealthy populations. That care coordination is really important. And we didn't have much of it, right, before we acquired the 85 clinics. It was a hospital where sick people came and got treated and got released. With 85 clinics, what we did, much like Robin's getting ready to do, is we embarked on a forklift IT replacement. So 20 months ago, we did a large Cerner implementation across all venue of cares. Every clinic, the entire ED. People say, what did you go live with? The easier way to say is, what didn't we go live with? So we didn't change our radiology packs, and we didn't change our cardiology packs. Everything else, lab, pharmacy, registration, radiology, everything went on one platform, all the eggs in one basket. So now we can attempt care coordination. The technology is frankly the easy part. The difficult part is, what do the humans do with whatever technology you put in place, and what's the workflow and the discipline with which they use so that everybody follows the same workflow so you can have consistent care coordination. So the technology, frankly, from my point of view as a CIO, is the easy part. There's a unique thing that happened because of Hurricane Katrina. All the communications went down except for text messaging. So we have one of the highest density of smartphone usage by the elderly by comparison to any other location in the country, so we're told by the carriers. So we're embarking to trying to get everybody, but even the elderly and those that are underserved or in a socioeconomic class where you typically don't have internet connectivity, we're trying to communicate, because most of our patients, 65 to 70% of our volume is a combination of Medicare, Medicaid, and the uninsured. Almost all of them have smartphones. So we're trying now to really reach out to them by that device that they hold in their hand to try to do some care coordination with them once we get our own house in order with how the providers and clinicians are going to do the care coordination amongst themselves. So those are some of the things we're doing.
I want to dig a little deeper in a little bit on mobile. I remember Dr. Karen DeSalvo, the national coordinator, told a similar story about,
New Orleans.
Texting was the only thing they had available. They didn't have even phone service.
Correct.
And of course, you've probably seen some of the pictures of all the paper charts that were wet and flooded and scattered around from the hurricane. And so they suddenly realized, well, maybe the cloud's not such a bad, scary thing after all. Not thunderstorm clouds like we have here, but the cloud for us to have our data securely stored.
Well, the other thing about Gene's background is you have a deep marketing background. So that understanding of people, I think, is such a unique combination with what the work you're doing in informatics.
Yeah, that we talked about it last night, right? In marketing and sales, there's probably some salespeople in the room, you're doing a little bit of behavior modification, particularly when you're talking about consumers, right? You're doing behavior modification. We need to do that in healthcare. We've got to do some behavior modification of certain populations of patients. You know, customer segmentation marketing, to use a marketing phrase, has a lot of analogies to populations and patient segmentation in general and patient segmentation behavior modification. So there's a little bit of corollary there that I like to draw sometimes anyway.
So Danyal, in Hartford, are you guys involved in any risk sharing or value-based contracting?
Yes, we are. So our health system has a major hospital, which is almost 700 acute bed hospital. We also have an ACO comprised of almost 1,800 physicians, so it's a large organization. And we are an MSP ACO. We're getting ready to take more risks, especially on the commercial side. I'm going to share with you an area where I'm comfortable, and that is really the acute setting. But I think it's of value in the domain of population health. In our hospital, ED boarding, meaning when patients come in, first of all, when they hit the ED, they wait too long to be seen. Once they make it through to the ED and they're seen and the physician decided to admit them, they stay in the emergency room for too long. And too long is not good for their safety, sometimes for delivering quality care, and absolutely it doesn't really make their experience pleasant, no matter what you do downstream. So we tackled this as an organization. And this is really focused on enhancing communication and collaboration between physicians. We have instituted the safety huddle, and that's a hospital-wide gathering of all the important operational folks talking about day-to-day, the previous day's issues. And then the largest admitting service instituted something called multidisciplinary round, and they've decided to localize their physicians to their units. And that sounds simple, but really what it's all about is bringing the right people together to talk about the stuff that matters to patients, and just bringing the team together on a daily basis to tackle through. Certainly when the clinical leadership thought that's really important, technology became an enabler. So we are an Epic shop, and we found different ways of using the tools to communicate among the various physicians on things that matter to patient. And we've instituted this solution over the past almost 9 months. And we have seen dramatic decrease in ED waiting time. And my opinion, and also there are a lot of different benefits, including around care coordination. But it was all about this whole basic concept of really a group of caregivers gathering together, talking about the patient. You'd think that happens on a regular basis in any health setting, but it's not really true unless you really make it a focus. And then the technology solution that we've adopted just enabled that process, and hopefully will help us sustain the benefits.
So, Robin, how's that center implementation going?
Yeah.
You guys signed the contract like yesterday or something?
Yesterday, no, last week.
Last week?
Last week we signed the contract. I'm so excited.
Have to hold you down.
Yeah, literally.
I'm so glad I'm not you.
No, it's going to be awesome.
Yeah, well, good. No, we are excited. We are very excited because there's so many opportunities for us that we don't have today. Even within the systems that we have, the McKesson system's not talking to each other, and we have WellSoft in the ED, and we can't get those records. So, and I'm preaching to the choir, obviously, about integration and sharing of data. One of the things, though, that we've done that is probably perhaps unique to Boca, because we have so many transient people. People come to Boca during the winter months from up north, to take advantage of the weather. They have homes, and then they turn around and they go back. So as a result of that, rather than the ACO principle, what we did, we affiliated with Northwell, previously North Shore Long Island Jewish. And we built a secure database that can be shared between New York and Boca, and the patients that come back and forth can share those records. They have a we set up a concierge service, 1-800-NY to Boca. Patients can call. They have a great marketing team.
Good marketing.
Yeah, that's
a great
good.
marketing team. And so the greatest thing about it was the collaboration. We all worked together. We had physicians, we had IT, and the clinicians and things like that working together. And what we were able to do was put concierges at each site in New York, in Boca, that help navigate for the patient. Yesterday we were talking about patient literacy and raising the level of education. And when people come down to the state, even though they might have a home, they don't know where to go, right? You have an emergency, where do you go? What do you do? How do you navigate through that? And so through sharing those records, we've cut back on the cost, we've cut back on the confusion for the patient, and I think elevated the level of patient care somewhat. And of course it didn't hurt that we increased some revenues as well, because we're directing patients, to the facility. So that was a great thing for us.
Great. So, Doug, I'm going to shift gears a little bit here and talk about the future as it is today, and in particular, mobile. Mobile health is a big, but population health, mobile health. You go to HIMSS, everybody's a population health vendor now. I was surprised to see that Xerox is now a population health vendor. I went by their booth, and nothing against that. I think it's a good thing. It was just surprising. It was just surprising to me. I didn't know that. And mobile health is the same way. So, but one person thinks mobile health and they think one thing, and then another person hears mobile health and they think something else. So, what do you think?
I think that health has always been mobile. I mean, ever since we've had phones and communication and the ability to shout at doctors or doctors shout at us. So the fact that we're putting new tags on, or we have new devices or new ways of communicating, but in essence, mobile health has been here for a long time, but now we have new ways of pulling in massive amounts of data from people. So we now have an opportunity to look at physical activity as a vital sign. So I think the wearable revolution is really giving us a new insight, because we know that influencing someone's health doesn't just depend on treating them when they're in our offices. It depends on understanding the social context. I mean, 50% of health status, or some estimates, are based on social determinants of health.
Even more.
And then, so I think mobile health has been here. We now have new forms and new ways of communicating to people. And for health systems, and I'm spending a lot of time inside of Innova Health, particularly in this area of bringing in precision medicine and the genomic profile, in addition to the wearable data, to really get a 360-degree view of the people we serve, and then move from really an episodic reaction area approach to, oh, I'm sick, we can heal you, to a lifetime womb to tomb sort of set of relationships, a relationship with the people we serve, and thinking through what are the business models that support that. Is it cost avoidance because we have a risk contract, or is there actually revenue to be made? I mean, health clubs, supplements, there's many businesses that make money. I think about this whole wearable business as sort of the super PERS business, personal emergency response system. If people are paying subscription fees for health clubs or other things, or help, I've fallen down, I can't get up, how can health systems potentially leverage those kind of subscription relationships to deliver a set of services to meet people? So I think that I think mobile's here. It's clearly not going away. We're all reinventing our lives through the number of screens we interact with, but how each one of us do it is different. So, we're in this realm of extreme personalization and really understanding how the people we serve use mobile devices. And I think the move for health systems to move into this area of customer relationship management when we're used to physician relationship management it's a big leap for us. And many health systems don't have the organizational structure or the marketing expertise. That's why I think Gene's background is so interesting, because of the combination of an informaticist who understands people behavior from a very extreme marketing perspective. And I think that that's one of the big leaps and gaps for many of the health systems in this room is really building out that customer relationship management structure beyond just capturing that visit information.
Yeah, and I think mobile is particularly useful for patient engagement, but also for physician engagement and for care coordination. Eric Dishman, formerly of Intel, and now he just took a job at the White House heading up the precision medicine initiative, has given a couple of talks around the theme of how healthcare is analogous to the PC revolution, right? And now the mobile revolution. So in the old days, if you wanted to do any computing, then you had a terminal into the mainframe. You didn't have a portable computer on your desk. And then eventually they started having, computing became more and more powerful and smaller, and you could have a server in your office. You could have an actual PC. Now you have laptops and PCs that are way more powerful than the big computers that filled a room 30 years ago. And now I've got more computing power in my pocket than I had on my laptop 20 years ago. And so, the analogy to healthcare is, just like you had to tap into the mainframe to do computing, now you've got the big hospital up on a hill, usually up on a hill because sometimes it floods, right? And if you want to get health care, you've got to have a line into the hospital, the health system, and then everything feeds in from there. But more and more now, the revolution is occurring where, just like in computing, where healthcare is being pushed out into the community. So now it's available at your Walgreens or your CVS. It's available even in your home, and through telemedicine and mobile technology, it's available right in your pocket. And so I think that there's a lot happening, but just the concept of being able to have targeted interventions that you can reach out and contact a patient, or just automated notifications to a patient where if needed, you can intervene and have a physical touch.
So I have a comment, follow up on what you said. One of the things that concerns me a lot is, in my opinion, the change that healthcare is going towards is really redesigning the way we deliver care and making the patient the center of that, bringing all the players around the patient. That is really important. That's critical. That's the strategy. My concern is if we adopt mobile solutions, wearable and others, and we haven't really thought through a strategy around the patient, how we're going to deliver the care for them, potentially we risk alienating the patient even more. An example to that would be if a hospital like us rushed into designing an access portal where the patient will log in and self-schedule an appointment. That sounds great, but if we don't really design the engine behind when the patient log in, we take that information, we plug them in the right way, and make sure we deliver on that mobile technology tool, the patient will be extremely frustrated and quickly will really lose faith in that tool. To me, so the technology is important, the tools are really important, but more important is the commitment and the team we organize around these technologies, how we deliver on them. And so my caution is, and it takes a lot, in my opinion, a technology solution is a lot easier than redesigning and rallying the team and changing the workflow so that we were able to deliver on that. So that's really my word of caution.
Danyal, I agree with that completely. My concern is the law of diminishing returns, right? the Internet of Things and wearables get so pushed out there, what do you do from a patient's perspective or the provider, right? I mean, there's probably a lot of providers in the room, and providers say to people like me, so I get all this alert data. What am I supposed to do with it?
Yeah.
It's in the middle of the night. How am I supposed to react to it? We don't yet have the systems to properly react to all this. A colleague at IBM, I'll use a phrase that they coined, their concern is what they call MUD, massively uncertain data. Because you have so much data, how do you get meaning or value out of that data? And I think I go back to the law of diminishing returns, and it's easier, frankly, from the consumer side, right? Many to few. There's a lot of consumers, patients. There's not that many providers in terms of the ratio. And so what are the providers and the care coordinators going to do with all this data? What action are they going to take so they don't let the consumer down? On another topic that somewhat relates, Doug hit on it, CRM or customer relationship marketing. In healthcare, if you want good examples, it's your plastic surgeons and your dermatologists. They got this down. They know how to go out there and do customer segmentation marketing. It's typically private pay, right? How do I go market to the right people who have the discretionary income to use my service as a plastic surgeon or a derm? They got this down. There's a good model.
And pharma, too.
And big pharma kind of push-pull, right? Hey, Doc, I saw this ad for Lipitor. We talked about this at the table last night.
Oh, I thought you were going to say Cialis.
Well, my wife goes to the doctor and says, they're like, you don't need Cialis. I said, never mind. It's a different story. Just kidding. On mobile, I'll give an example that as you were talking. Thank you. A little therapy there.
That's good topic.
It was really just, never mind. Some friends of mine owned some dialysis centers here in Houston about a decade ago. They've since been bought by DaVita. But back in the day when it wasn't, free minutes, right? When it's all you can eat. I used to buy minutes. They had a problem with patients showing up, particularly in a certain demographic, not showing up on time, which is really important for dialysis, right? And so what they started to do is if you show up on time, we will give you free minutes. And for a certain segment of the population, like the on-time rate went up into the 90s as opposed to somewhere in the 60s or 70s, just because they got free minutes on their little flip phone. And this was a decade ago, just one small example.
Well, and that's understanding that particular group of people and how they respond, and that's the one-to-one marketing world we're in. I mean, within 7 milliseconds of a search on any device, that information's resold multiple times.
Yeah.
So Innova, we're looking at programs that right now typical health system touches a person maybe 1-3 times a year between your ambulatory and your hospital. How do you touch somebody 200 times a year? What is that location? It's the grocery store. How do you create a social network around food and make that interesting and fun in your community? And then you have actually these data points of how people are eating, because how people eat, nutrition is another vital sign along with physical activity. And if we're truly going to be responsible for a health of population, we have to start looking at that kind of information.
So reaching out and touching them, Doug, you maybe, somebody said, made me think of it. So HIMSS, AT&T calls up and says, we'd like to have a meeting with you at HIMSS. Like, we use AT&T for some broadband and things. I'm like, why should we meet at HIMSS? They said, well, we're a population health company. That's who AT&T is today, because we can touch everybody, all the consumers you want to reach. I'm like, AT&T now is a population health company? Really? How interesting.
Yeah, everybody is.
But it's much about knowing your own demographic as well.
Right.
I mean, in Boca, our median age is 73 years old.
Wow.
But we can't be so short-sighted, because if we don't pay attention to the younger demographic, because eventually those 73-year-olds, as we all know what happens, but it's going to shift and it's going to change, and the habits are going to be different, and what they use and how they access information will be different. We had a discussion last night at the table that was very lively around Snapchat. There's Amanda. And so anyway, we were talking about that, and the thought process, if we don't incorporate those things, we spend a lot of time thinking about our core systems, right, and doing those enterprise systems, and because we have to, because that's what helps keep that organization going. But what direction are we being given, or are we devising ourselves that are going to take us to that next core? What is that next core? How do you incorporate communication with that younger generation who are constantly doing this?
Right.
I mean, if you have kids at home, this is what you see, the top of their head. So they might as well put messages up here, because that's what you see. But you have to build towards that, because that's their world, right? That's what they understand. That's their socialization. That's their information. and it's how we need to market to them. And you know, from a perspective at Boca, we've been so focused on that older demographic and how they relate and how we provide information and care to them that we've lost sight, I think, of what's coming.
But you did customize for your group because you connected the databases between New York and Florida. So that those are your frequent flyers, and you did something that's very different and very unique to meet their needs.
You know, both of you hit on something, you and Gene hit on something. When he talked about the flip phone 10 years ago, and you're talking about kids these days, you know, the smartphone's become an appendage. It's just a natural part of who we are. But yet, when was the first iPhone? You know, prior to that, people had Blackberries, but they weren't all that smart. And so, just in the last decade, it's really quite remarkable. You know, you go to the airport, everybody's looking at their phone. Everybody's emailing, they're on Facebook or whatever they're doing. But it's sort of it's an augmentation of ourselves using these technologies. And even the older generation is starting to adopt this. My grandmother blows me away. She's got a smartphone, she's on Facebook.
She's got more followers than you on Twitter, right?
Yeah. She I don't think she's using Snapchat, but you know, I saw a grandmother, a politician running for office that was talking about Snapchat that's a little younger than my grandmother, but it's catching on with the older folks. Yeah. And there's a whole lot of other applications, I think, that might be useful.
Well, I think it's that connectivity, too, because we have that demographic in Boca, and yet their children are elsewhere. And so being able to effectively share that information, you know, because if they pick up the phone and call, we're not going to release, you know, a lot of that information. So how do you connect them to the care that you're giving to the parent, or you know, to the relative?
You talk about how you do that with that population, right? So right now our problem, meaning the country's problem, right, is the elderly, and those of us that are going to retire out and be put on some kind of a Medicare program. The millennials don't yet think it's a problem. So there's kind of two different audiences. The millennials are going to expect online registration and lab results coming back and expect all of this and expect to communicate with their provider. That's an expectation that I think we should be acknowledged they're going to expect. The issue is, how do we deal with the population of people right now which are costing the system the most and aren't yet coordinated with that kind of connectivity that we know millennials are going to have and that we can actually deliver. That's not the hard part. The humans, again, are the hard part. So I think that's kind of what people like us in this room ought to think about, is how are we going to address those two different markets, if you will? Because right now, unless we address the cost issue associated with the elderly, there's going to be more of us going there, that's going to be the issue that kind of, as we all know, breaks the bank, if you will.
But I think the other group that is the boomer, right? I mean, we're forever young, right?
I'm already saying, that's what I mean by the elderly.
I thought it was elderly.
No, I meant those.
Elderly, not us.
No, but I think the boomer population is the one. Look, disposable income, opportunities for these innovative subscription relationships. If we can deliver value to their effort to be forever young. Why is it just about the hip replacement? Why not 6 months of prehab and 2 years of post-hab with services bundled around that leads to a $50, $100 a month subscription fee to the health system? I mean, we have to look at really meeting the needs of, once you lose your hip or knee to an implant, then the Gold's Gym may not be the best place for you. You need a medically monitored, supported routine relative to maintaining what we want to be is forever young.
Yeah, medical fitness centers. You know, but it's not just the generational divide for patients and consumers, because the clinicians, there's also a generational divide. I used to do some work for the ONC when the HITECH Act was first implemented, doing some consulting work, and got to travel all around the country talking about it, and had, you know, physicians just weren't happy about this at all, by and large. But there were some that were, and they were generally younger. And actually, this is 5 and 6 years ago now, but at that time, it almost seemed like about 50 years old. If a doc was older than 50, they said, "I'm not doing all that. You know, I'm not bringing a laptop into the exam room. I'm just not going to do it, and I'll retire before they can force me to do it." But the younger docs were saying, no, I want that, but actually I want it on my iPad. I want it on my iPhone. I want to be able to refill a prescription from my iPhone. They were pushing the envelope ahead of even where David Blumenthal and Farzad Mostashari were already going. And so I think, you know, there's a bit of a millennial baby boomer age group tension there too, where the adoption of technology for the younger clinicians is pretty rapid, and they, just like patients, have an expectation that, you know, they want to be able to email their provider. Well, you know, a few years ago, that was anathema to most physicians. They said, I don't want my patients emailing me. They thought they'd get buried in emails. But a number of studies occurred. Group health up in the Northwest where I'm from, you know, they've been allowing patients to email their physicians for years now, and it actually created less work by being able to have that, rather than have them call and then leave a message and somebody has to call back and do the ping pong back and forth. They could send an email and then get an answer and be done with it. So I don't know if you guys have any, if any of the three of your hospitals are doing email with patients.
Yes.
Yeah. So we use Tiger Text, and we have allowed some groups to use secure email channels. Now, I want to pick on the point that you mentioned about physicians divide on generational their approach and the acceptability of the technology. I would say the revolution is a real earthquake happening in the way we are organizing care. In many ways, people say the physician used to be the center of the most important person on the team. The truth is that's no longer necessarily the dogma, or necessarily the truth. Is now there are a lot of disruptors out there who've figured out a big chunk of care that can be delivered for those who are not even clinicians per se. A really good study that was just released recently from the Mayo Clinic looked at readmission for COPD, a chronic condition, lung condition. It's very hard to treat. And they've invested heavily in health coaches. High-touch program, very well thoughtful, designed, focused on understanding the disease and the characteristics of the people who have the disease and their circumstances. And if they've designed or redesigned care such that they have this health coach that have high touch, we're talking about, in my mind, the technology is an enabler. If I can really deliver the high touch using an app or web-based or even a phone, is fine. But the key is the high touch, the health coach going out there, keeping in touch with these patients, addressing their issues, and they enable them. They use motivational interviewing, very smart way of listening and figuring out where you are on the stages of your readiness for change and reacting to that. So I go back to this. I don't believe that technology is the magic bullet, so to speak. I truly believe it comes down to us, the humans, the care team, figuring out what the needs for the patients are and connecting with the patients as if we're talking about family. We family text and get connected and keep connected. But we're family, meaning if my daughter texts me, I'll text her back. If my wife, my friend. But generally speaking, if I receive a text from somebody I don't really know, most likely I will not reply. The same need to apply, and the care team design, in my opinion, is our patients need to feel that they're included in that design, and then we respond to their needs as promptly as we would respond to our family. And using the apps or the various technologies, in my opinion, are absolutely become enablers and help us sustain that initiative.
So are you reaching out through text messaging and Tiger Text to create that kind of relationship?
Yes.
Or are you seeing that happen with your patient groups?
Yes, absolutely.
But in healthcare, at its basic form, is people. It's people helping people, and like you said, technology is a key enabler, but it's not the end all be all.
And we have to be very careful about how much that we don't inundate physicians, I think, because even though we see some of that generational divide in terms of technology at our organization, we have a strength, I think across generations. But what I did find was that it's kind of like drinking from a fire hose, right? You can throw so much information that it's just overwhelming. How do they keep up? So, we've all gone through and done our health information exchange and process lab and RAD and CCDAs out to the physician's office. But when we went out into the physician's office, found out that they were just bottled up in this queue that they couldn't get to, right? So how relative then does all of that information become to the care of the patient? So for us, it was a matter of working with the physicians. What is important? What do you need to see? Do you need to see everything? How can we filter information for you? So how can you make it seamless? How can you make it relative to their workflow? Because that's really important. That's what's going to make a difference, and that's what's going to help you use it.
You and I had talked about that, leading up to this conference, and if you're a physician and there's a transition of care that occurs, and so you get sent a consolidated CDA document. Let's say it's a small one, 17 to 25 pages. And now that's in your electronic medical record. And now you're responsible for all that information. It's very easy to miss something. And you just get piles and piles of that stuff. After a while, it becomes overwhelming. They don't even want to sign off on it because they haven't had a chance to adequately review everything. And so you can be buried in too much information. Big data can come collapsing on top of you. Well, that's why I think one of the really useful tools that is now starting to emerge is the FHIR standard of HL7, F-H-I-R. And what it does is it allows you to do data calls on just the bit of data that you want. Basically the header from a consolidated CDA. So if you just want meds or allergies or a problem list or results, all the different things that you might want, you can just and then people are developing mobile applications to make with nice UIs to make use of this in a really good way. And so I think the next couple of years, hopefully some of that issue will be a little bit mitigated through these new standards.
It's almost this companion. We're going to have this companion called a life or health record with omic and genomic data, but also wearable and digitalized data. What gets pulled in depends on the patient, the conditions. What gets pulled into the medical record depends on that intelligence and what you call the filter in the cloud.
Yeah, and when you add in genomic data, then you really have a lot of data.
And this is where, Brian, I say, the good thing about technology is it scales, right? But you got to remember, scale can work both ways. It can be a positive and a negative. This scales massively to the point of its overload. It's law of diminishing returns. You just get provider, patient, you get inundated, and therefore you stop reacting. One example is on email. I'm just being transparent for the vendors in the room. 90% of my inbox is junk, so I've gotten to the point where I pay attention to none of it. If I don't know who it is on my inbox, I simply get rid of it. I don't have the time to filter through it. I haven't answered my desk phone in probably 9 months. There's just no way. On the one point, Brian, I apologize for you talked about the physicians and what we did, Robin, before go live, and I'll give our chief of staff then our CMIO now the credit, mandated that every physician has to do a PC skills assessment online, and we train them because some of them, typically in an older age category, not their fault, had never used anything Windows-based. Minimize, maximize, drop-down, radio button, predict. They knew none of it. And so that was a very valuable tool because they'd done 100% of their clinical life on paper and had never used a computer for anything, not even at home, some of them. Yeah. And that was a big, and then you have the younger ones, like you said, pushing the envelope of give me more. I don't know if we're fortunate or unfortunate, those of us in this room, this is the transition in healthcare, right? Future. I don't know what it is. In 3, 5, 7, 10 years, this is done. It's all electronic. Everybody will expect it, physicians and patients. But I think this is a transitional period.
So I think we've got about 3 minutes left. So I'll just go down now and maybe get some closing comments from each of you. We'll call that your closing comment, but we'll circle back to you and let you say goodbye.
So Doug, I'm going to close and picking on something you said about the wearable and genomics and all these amazing aspects of data that we can collect. But the truth of the matter, medications and medication side effects and reaction result a lot of hospitalization. We hurt a lot of people unintentionally because we don't understand how they use their medications. And we don't manage their medications well when they come into the hospital. I'm just saying we need to take a deep breath. We need to address the basics. I mean, I love this amount of enormous data that's really going to come our way. But we really need, still we have a lot of work to do. And first of all, fixing the whole issue about medications. And that's so simple. Medication lists, when they come into healthcare and interact with us, we don't do a really good job. So I bring it back also again to the very basics. I think it's all has to do with the way we care for our patient and the way we should involve the patients in the care redesign and be very, very deliberate. Then I believe then only then all these massive amount of data that are really relevant that can be ingested in a way that's thoughtful.
Yeah, medication reconciliation is key. Patient portals are great. I've got 5 of them from the different healthcare organizations I receive care from, and none of them have the same information. None of the med lists are the same. It's a mess, and so we've got to get better at that.
So I'm going to follow basics. Basics. It's not about the app, it's about the service. And if we want to connect with people today, let's start with the basics. It's texting, it's what you're doing, extending the text message out and that capability. And being able to hit my care team, hitting my text message is like a family member. So I think that's my closing comments. Let's focus on the basics, and 99% of the people with a mobile phone text, and they respond to text. And that's where we need to go, is a blocking and tackling.
All right, well, Robin, take us home.
Just to take us home?
Yeah,
Oh,
we're done.
And so what I would say is just start, because it all seems overwhelming. What do you think about? What direction do you take? How do I maintain and manage meaningful use and my systems and my users and the physicians and the demands placed? But I think starting and looking at those philosophies, if you just start and you involve the right people, where you end up may not be where you thought you were going to go, but you have to start down that road. You have to pay attention to it, and you have to make it valuable. We do the multimodality clinics, as you've explained, and I think that from a cancer treatment perspective, has been one of the most valuable things we've ever done. And that's because they started. They involved the patient, they involved the caregivers, they involved the technology. And someone said last night, why is IT not at the table to begin with for the strategies, right? And you should be. You have an obligation to be involved, to understand why it's important, who your demographic is, who you're serving, and how to do it better. And we have the tools. We can always provide the tools. You just need to pick what's important and start down that road and find your path, I think.
Well, and I guess we're going to circle back to you. I guess we do have a minute and a half left for you.
So I would suggest we start with, because we can touch patients now other than the encounter in the exam room, the unmanaged, manageable condition. We're in Gulfport. We too will see 80,000 ED visits this year, many of which, we know primary care comes there, but they come in with an unmanaged, manageable condition. And if they had been managing their diabetes or their hypertension or their obesity, they wouldn't be there costing the taxpayer a couple $100,000 over time. We could care for them a lot less on the prior 3 or 4 or 5 years for $10,000 or $20,000. It's the unmanaged, manageable condition where I think the big opportunity is to connect however we want to do it, face-to-face, in writing, electronically, mobile, whatever it is. But for me, that's the big one, is the unmanaged, manageable condition.
Yeah. And in Oregon, we have something called CCOs. It's sort of like an ACO wearing an Oregon Ducks sweatshirt. They're coordinated care organizations that the state, the Governor Kitzhaber at the time, got waivers from Medicare, from the Affordable Care Act, to implement sort of a progressive, forward-looking way of providing care to Medicaid recipients in the state. And one of the things that they talked about was they had done some environmental factor studies and said, well, we've got this problem with COPD. And looking at weather data, looking at location, and looking at the patient's condition, realized that, and their economic status, realized that if only they had an air conditioner, those hot, muggy afternoons in the summertime, they wouldn't they'd be in a lot better health. Air conditioner, you know, you could get one for $300-500, put it in their window, and save an awful lot of money. But of course, air conditioners aren't covered by Medicaid, right? So they changed that, and so you can change the way you pay for health and wellness in the community. That can save a lot of money. You know, keep someone out of the ER and help them to manage that manageable condition, and it saves us all a lot of money and improves the health. Improve health, lower costs, and I think he's giving me the hook here.
Triple aim. You just said triple aim.
Yeah.
You just,
Good job.
Thank you so much. So the next sessions or your meetings, workshops start at 8:55, so we probably have a couple of minutes, if any, for like 1-2 questions for the panel, if anyone has, or we can have a 10-minute coffee break. It's up to.
Or we could have a coffee break where you can ask the panelists questions.
There you go. See? That's why Brian's moderating, not me. One more time, thank you, Brian, Jean, Danyal, Robin, and Doug.
Don't walk off with your...
You guys can stand.